Good afternoon. It's great to have you here. I think at all these kinds of events, I'm always shocked when there are more than people who are up here on the podium just for talking. I'm always surprised when people show. And so thank you for coming, and I really appreciate that. My name is Pam Teester. I'm a professor, and I'm the director of the Center for Gerontology at Virginia Tech, and I suppose most applicably today, I'm a bioethicist. So it gives me a great thrill to be among this group of the Palliative Care Partnership of the New River Valley. And I absolutely know that if you got interested and wanted to join us, you could. It would be really great. And so this is one of our first presentations, I think, that has been quite a bit in the making and is really a great partnership between Lewis Gale, the Sojourn Center, Carilion Clinic, Virginia Tech, all those wonderful, and more, as one can say, all those wonderful things coming together to talk about advanced care planning. And why it is important probably is why you're here. I am very, very pleased to be here to introduce these folks who are going to talk about advanced care planning. They have great backgrounds. They've been interested in this forever, and it has been my great privilege to get to know them all a little bit better. So let me just introduce them, and then I'm going to let them get started and get out of their way so I can take some notes. Ed Spencer, I suppose he's the easiest person to figure out. Retired as Vice President for Student Affairs at Virginia Tech, and now serves as Chairman of the Board for the Directors of Warm Hearth, and is Vice President of the Sojourn Center Board. I love to get to go to meetings with Ed because Ed runs great meetings. That's a great hit. Nicole Thompson is a registered nurse with over 30 years of experience, received an associate degree in nursing from the Jefferson College of Health Sciences, followed by a Bachelor of Nursing from VCU, started a career as an ICU nurse and remained there for almost 25 years. She transitioned to hospice nursing where she found her true calling. She's certified in hospice and palliative care and recently earned a Master's of Science in Palliative Care through the University of Maryland, Baltimore. And I know going back to school is not easy. I can do that myself. Okay. Nicole Bailey is a licensed clinical social worker with Carilion Home Health in the New River Valley. She has been in this role for 12 years and developed a passion for advanced care planning early on. Nicole is a certified dementia practitioner, a certified advanced care planning facilitator, and instructor. As an instructor, she assists with training clinical healthcare professionals across the state. Heather Linkus is a certified family nurse practitioner for Carilion Hospice and Palliative Care. She is an advanced certified hospice and palliative care nurse with 14 years of hospice experience. Ed, I just love you outright. But you nurses, I have great, strong love in my heart for you because my son is one, and I expect he's winding up right now with the next cardiac surgery or transplant. I will lead you to the most interesting part of this presentation.
For a while there, Pam, I was trying to figure out why you said I was the easiest person to figure out. I was looking too deeply rather than this. Well, let's start with a definition of what is advanced care planning, and I highly recommend the NIH booklet that is back on the table. You're welcome to take home copies of anything back there today. They define advanced care planning as a process through which individuals make decisions about the medical care they would want to receive or not want to receive if they became unable to make or communicate those decisions themselves. Pretty concise definition. So it involves discussing and documenting one's preferences for health care, especially in situations where they may face serious illness, injury, or end of life. Primary goal is to ensure that a person's healthcare wishes and their values are respected and followed, even when that person can no longer express those himself or herself. Why advanced planning? Pam referred to this. Death can occur at any point. It doesn't wait to be a senior citizen necessarily. And so the importance of doing it early on cannot be overemphasized. We need to be prepared for that possibility. Second, it is far better to discuss and plan in advance of some health crisis than it is in the midst of it. You think about that, how difficult that is. It's better to have that discussion before a crisis is involved. And this helps with maintaining calmness and getting disagreements aired and resolved, hopefully, in advance of a difficult situation. It saves speculation and guilt later on. Well, what happens if no advance directive is in place, for example? The laws of the state will determine how things will proceed in a death. In most cases, the order of determination would be spouse, then parent, then adult children, and so forth. And it's likely, for example, that a partner would be excluded if he or she was not named in an advance directive. So what are some situations where this might occur? Well, I've jotted down from my own head 3 examples so that as we talk through, you can think about these situations and how the information relates. Let me give you scenario number 1. A father is in a car accident and suffers very serious injuries. He's been placed on a ventilator. He is unlikely to recover and regain consciousness. He is married and has 3 adult children. His wife wants to preserve his life for as long as possible, as does one of the children. The other 2 want to remove the ventilator and, quote, let him go. Think about, well, what happens now? What should have happened a long time ago? Second scenario, Carol is exhibiting signs of dementia and acknowledges this. John, her husband, is in denial about the whole thing, and one of their adult children shares the husband's approach. But the other sides with mom and wants to initiate the advanced planning process now, even though dad and sister are opposed to doing so because it would be too stressful. What should happen now? What should happen a long time ago? In the third case, Miguel and Jorge have been in a committed gay relationship for several years, but have never executed any documents. Miguel, who is estranged from his parents, suffers a serious fall and concussion and is unconscious. A decision must be made about whether or not the medical personnel should engage in extreme surgical procedures to perhaps restore his well-being. In these no advance planning directive circumstances, the state law dictates that decisions must be made by the parent from which he's estranged. What should have happened earlier? What should happen now? So keep thinking about that as we go through and talk.
So I'm Nicole, and I actually love those scenarios. Those were great, and y'all really should kind of keep those in mind as we talk through these things because they're not far-fetched. I work at the hospital, and I see and work with situations like this day in and day out. And I can tell you from lots and lots of experience, it is exponentially easier to make decisions for your loved one when you know their wishes. So I'm going to talk to you a little bit about what actually makes up your advance directive. So my talk is pretty practical. But each advance directive, and there are numerous forms out there you can use, and we're going to talk a little bit more about that in detail. But they are going to have varying degrees of decision making on there and places where you put your wishes. But each and every one is going to have 2 main components. Number 1, you're going to designate your healthcare decision maker. And I'm going to expand on that a little bit more, but I can tell you right now that is, in my opinion, the most important part of what you're going to be doing. The second part is just where you lay out your wishes. This is where you're going to say, if this, then that. You know, if this is the scenario, this is what I would want. And again, we'll go through that in a little more detail. But those 2 components is what's going to make up every single advance directive out there. Now, I said that I think the naming your decision maker is the most important part of this, and I'm going to tell you why. So I have an example, and I think we've got some of these forms that you guys can take a look at. But this is the Virginia Advanced Directive for Healthcare. You can just download this right off of the internet. This one's pretty detailed. It's got lots of questions, lots of places to put what you do and don't want. But the very first part is who I picked to be my agent. As we've just heard in some of these examples that Ed gave us, naming that person is so very important because you want someone, if you are in a position that you cannot make medical decisions for yourself and someone else has to do it, who do you want that to be? If you don't have a relationship, for instance, with your parents, and that would be, according to the state code of Virginia, that would be the person that would be your decision maker. I strongly suggest you find someone else. The directive part of this that tells what you do want, what you don't want, what your wishes are, that's basically kind of just guidelines for that person who is going to be your decision maker to go by so they know your wishes. Nobody has to do what you put on here. They don't have to follow what you have said. It is very, very important for you to say, this is what I want and this is what I don't want. But ultimately, the person that you have named as your decision maker is going to have decision-making ability in the situation where you are not able to make your own decisions. So the reason I point that out is because I think sometimes people think, okay, well, I'm going to pick my oldest child just because they're the oldest, and so that's going to be their job. But if your oldest child is going to keep you on a ventilator for 40 days just because they can't let go, even though you've said, I don't want that, I would strongly suggest you not pick that person. So, you want to have these discussions, and kudos to all of you for being here, because it is hard to talk about the end of life. It's hard to talk about dying. It's hard to talk about what our wishes would be. We really it's human nature that we want to avoid this discussion. But the fact that you're here says that you're interested in talking about it and you recognize the importance of it. So that's wonderful. But in filling this advance directive out, and when you choose the person that's going to be your decision maker, be sure and talk to them about it. Let them know, I want you to make decisions. You probably should get permission from them to list them as your decision maker. And then talk to them, let them know, these are the things that I'm saying I want or that I don't want. And then if and when that time comes that they have to sit down, they're getting that news from the doctor. You can't make decisions, and so now they're up to bat here. It's their time. They have to make these decisions. If you have talked to them, you've made your wishes clear, you've even taken the time to document that, put it in this form, it's going to be so much easier for them to say, for instance, she always said she didn't want to be on a ventilator. Let's remove the tube and make her comfortable. Or, no, I know that they've just had a stroke and can't eat, but she was very clear she never wanted a feeding tube. Then you can make those decisions because you've had that conversation. It's so much harder when you're in the heat of the moment and emotions get in the way. And I'm telling y'all, like I said, I work in this every single day, and I walk alongside people, and when we don't have one of these, when we don't have the advance directive, we're kind of just trying to talk through it and say, has she ever said anything about what she would want in this case? Or did he ever mention, what he would want to do? And then, you're kind of trying to just piece together a story in order to make decisions. With this in hand, you know what they want. And because, they've chosen you, or you, the person that you've chosen, and took the time to talk to them about it and let them know what you wanted and what you didn't want, they're going to be able to make the decisions that are in line with your wishes. So I think Nicole's going to talk a little bit more, and we're going to expand on this and talk about, all these decisions that may need to be made. But again, my take-home message is choose your decision maker wisely and talk to them and let them know what you want.
Thank you, Nicole. That was such an important message because I wholeheartedly agree we need to think very wisely about who's going to make possible decisions for us in the future. So what are the benefits of advanced care planning? Well, you've already heard a lot that's already been said. Empowerment. It allows us to be able to make future healthcare decisions when we cannot advocate for ourselves, and that is so important. When we look at the reduced family burden benefit, we don't, without these conversations, without involving your healthcare agent, that's a lot of stress for our family. That's a lot of stress that they're dealing with a lot of other emotions, and then they don't know what mom or dad wants, or they don't know what grandma wants. It really, really helps reduce stress. And it clarifies our values and our wishes. It lets our medical professionals know what are acceptable outcomes and what may not be acceptable outcomes. So I think that's really important because clarity in what we may or may not want at end of life or with certain treatment options is really important. So we know that it's very valuable and we should be doing it. So what are some strategies when you're thinking about maybe having a conversation or even self-reflection or getting mom around the table? What are some strategies to start that conversation? Honestly, every communication, every type of heavy type of conversation really should involve an open mind, a comfortable space, and really a lot of active listening. This is for the person to really work through and reflect on their values and really share that with the family, their healthcare agent, to understand and navigate what may be unacceptable outcomes. And I think that's really important because of this situation. We don't do enough of clarifying and exploring phrases. So when I have these conversations a lot with patients and their families, and I hear a lot of times, what is a good day for you? What in the future would be something that would be unacceptable with your care? And a lot of times is, I don't want to be a burden on my family. I hear that a lot. And I think that's a very common theme that many people can feel. But what does being a burden mean to that person? Because my definition of being a burden on my family could be so different. So we need to explore phrases and words and really, really delve into what that means to your loved one. Because that's going to help make sure that their wishes are known and respected. So it's really important. What about when we have family members that are shut off to the conversation, right? I mean, again, you put it out there, it's gonna happen, right? It's like you say, I wanna do my advanced directive. Oh my gosh, I'm gonna die tomorrow. I think that's what people think. I mean, I can understand that. You don't wanna put it in the universe. But the reality is that this is such an important conversation, not only because it's allowing our healthcare agents and our loved ones to know, but it's also taking off the stress of ourselves, right? You've got that big thing in the back of your head, I should have done that already. Well, I think when you're trying to talk with your loved one and there is that barrier, we need to remind them about what I said in the beginning. Why is it so beneficial? It's gonna help me, Mom. It's gonna help take the stress off of the family. We wanna know what you want. And I think a lot of conversations that I have kind of come to an aha moment when you start talking about life experiences, right? So Sue down the street, her husband was in a car accident. They never talked about anything. She doesn't know what to do. He's on life support. Gosh, I mean, how agonizing for that person. So I think we need to look into kind of connecting on somebody else's experience, because that's kind of human nature, right? So when somebody else went through something, it kind of makes you reflect, well, I don't want that to happen to me, or I want it to be done different. So I really think that's important. So really sitting down and kind of connecting on those life experiences, and if another family member had gone through something. So I think that's really, really important, especially when you're trying to connect and kind of get over that barrier of maybe helping your loved one complete this document. So kind of looking through validation as well. I know that it's very hard to talk, right? Talk about end of life. And I think that we kind of jump over the fact that when we are having these discussions, that it's just, let's fill out this form. No. Planting seeds, right? We don't have to know it all. We can sit down with our loved one. We don't have to have all the answers, but we can start a meaningful conversation. And once that starts, even if you don't get the form completed, you can pick up other times when it's appropriate. So I just don't want people to think that you don't have to have all the answers. Like if there's medical questions, write them down, take them to your doctor. I think that we, myself included, put a lot of pressure on knowing everything and wanting it to be, this is what we're doing, this is a task. The conversation is just as important as the document. So it's not a sit down and it's all done in one time period. I mean, sometimes it is, sometimes it's not. So I think just really planting seeds also takes the stigma away from advanced care planning and not wanting to, people don't really want to talk about end of life, and there's still a stigma there. So I think just, really making sure that we know that as long as you're having little meaningful conversations, that's what's important. And so I'm gonna hand that over to Heather so she can kind of talk about the different documents and her side.
Thank you, Nicole. My discussion is going to piggyback kind of off of all the other panelists' topics. So basically at this point we're going to talk about where to document, how to document, who to do this with. So that's what a lot of these documents will pertain to. The first one, like Nicole mentioned earlier, is the Virginia Advance Directive. So like she mentioned before, you can appoint your medical power of attorney or your surrogate decision maker, but you can also list your wishes as well. And so I think a lot of these can also be used in conjunction with each other. The second one is the National Pulse document. So this is a physician order. So what this is you can take this in just like any other document to your physician, to while you're in the hospital, keep it at home. And basically this is where you can become very specific about what decisions you want to be made with your healthcare, such as, do I want CPR? Do I want to be on a ventilator? Do I want to have tube feedings? Do I want antibiotics? And as your health, if it decreases over time and you feel like your health is worsening, then this can be modified as time goes on. We encourage people to do so because you might complete this document today in the current health state that you're in and you think, oh, I'm doing fine, I want this, this, and this. But when you really come to think about it, as your health declines, you may not be as mobile as before. You may not be able to do the things that you were able to do, even for yourself, like feeding yourself, or even getting out of bed, taking a bath. So when you're in those type of states, would I really want all these interventions? Is that a quality of life for me? And so I feel like whenever I encourage patients and families to fill out these documents the main theme would be, what do I consider quality of life? Because in healthcare, we can do things to people, anything. Especially this day and age with technology, there's always things we can do to you, but are they going to benefit you? Those are two separate topics. And so that's what, when I encourage patients to look at this is, what is quality of life? Do you want these things? If these interventions don't fit into what you consider quality of life, then let's not do them. And so, like I said, if you fill out something now, this can change as time goes on. And that's the great thing about all of these forms that we talk about, is that they can change as time goes on. It's not just a one and done, So The national policy, it used to be that it was state by state, but now they have advanced to where it's recognized in all of the states, so you can carry this with you from state to state. This is a physician's order, and so the caregivers who you might be in contact that might access this, they have to go by what is in this. So this is something that you will discuss with your doctor, nurse practitioner, physician assistant, and this could be in a doctor's office. You can even have these completed if you're ever hospitalized. And so the two of you will go through what your wishes are, and they can explain more about certain situations that you might come across depending on what is going on with your health. You know, if you have heart failure, they might say, well, here's the things that you might expect along the way. Is this something that's meaningful to you or not? And so you can go through the motions and they can answer questions on specifically and individualize it to you rather than this just general type of do you want this or not. So I highly encourage, this is very specific and it kind of takes the guesswork away because you really just check boxes and it has kind of, you know, a lot of choices available to you that you can just pick from. Also on this form you can pick your surrogate decision maker. I really encourage each and every one of you to have something like this at home. A lot of the pulse forms, you know, you might see this mostly with patients who are really sick, maybe have end-stage disease processes, that this really targets to them. This is who I definitely encourage because it's very specific and it really talks about advanced treatments for advanced diseases. So you may not have these type of things, you know. In our current state of health, we want antibiotics. We might, you know, even want temporary tube feedings to get us over a hump, you know, for receiving cancer treatments or something like that. But if we get to a certain part of our life where we feel like that's not going to be beneficial or that's not something that we consider quality, then we may not want to visit that. And that kind of piggybacks off you can have this in conjunction with your advance directive. Yes, ma'am.
Clarification, so what was that form that you were holding up that was not the advanced directive?
This is the POLST, P-O-L-S-T, and I think do we have copies of this, or can we pass this around?
Yeah, we can pass it around.
So you can look at this as well, but it's P-O-L-S-T, and you can get these at your doctor's office, hospitals, and it's really easy form that you can request to go over with your doctor.
Thank you.
The last form we have here is a durable do not resuscitate order. And so you might hear this in the public about DNR. So a lot of people just know it as a DNR. So what this means is that you have decided that if your heart should stop or you stop breathing, that you want to just pass peacefully and naturally with no intervention. You don't want CPR. You don't want to be on a ventilator. You don't want any type of medications to stimulate your heart to bring you back. And so this is a form that I feel like all three of these should be in a safe place together because the doctors and the nurses and everyone in the healthcare is going to want these all together. They're going to ask you about these. And so your surrogate decision maker as well as yourself can fill out these forms. It's very simple. It's very straightforward. And basically it just says that you are declaring that in this circumstance that you do not want any interventions. And so then a nurse practitioner, physician assistant, any of the providers can fill this out and sign this. You just need to sign this and they can give you copies. So I think this is one of the main things that we, especially Nicole and I, we talk about greatly every single day. Because people don't understand how brutal CPR is. And someone who is already medically fragile, their body is fragile, their health is fragile, likely that if this process occurs, you're going to endure suffering and no benefit. And it's a very low chance that someone's going to live in that kind of state. So we heavily encourage people to not endure suffering. You know, a lot of our role in healthcare is to do no harm. And in a lot of circumstances, especially that Nicole and I see, we're doing harm. And so that's where I feel like this could make it very clear. If you sign the document yourself, no one can change it. Same thing with the POLST and same thing with the advance directive. All three of these documents, if you sign them yourself, no one can change it. So you don't have to worry about someone in the last minute saying, no, 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 do everything, do everything. Because we've had those too.
Yes.
People wanting to rescind and say, no, 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 just because out of fear of losing their loved ones, they panic. But if you sign the documents yourself, they won't be rescinded. And until you change those are set in stone. No matter if it's 20 years ago, if that's still the document that you have before you, they still have to abide by it. There's no limits on the amount of time that goes by between documents. We encourage as time goes on, what you might put down today might be different tomorrow down the line, depending on what's going on. So we encourage as time goes on, even young people, you might put something down today, but as time goes on, things may change and you can change this at any time. And it's as simple as even going through a doctor's appointment and asking your doctor or nurse about, do you have these forms and can we fill them out? And that's where specialists like Nicole and I, this is the bread and butter of our day, is we have these conversations and fill out these forms all day. And that's the goal of our consults at the hospital, is because we are trained to have these conversations with people, and we could really, yes ma'am.
Sorry, you said that nobody, if you sign it yourself, nobody can change that.
Right.
The only exception to that is if you name an agent, though, right?
No. If you sign it,
The advance directive is just, it's a directive, right? It's very an important form, but that can, your healthcare decision maker, so that's why Nicole made the point, make sure you're picking somebody who's gonna respect your wishes, because that can, your healthcare decision maker can go against your wishes. When you do a POLST or DNR, that is an actual medical order, so a doctor signs that. So that's where it cannot be revoked. But
right.
And also a POLST and a DNR are not going to be for everybody. The advanced directive is at 18, and that should change with us over time. When we're getting into a POLST form, DNR, medical orders, it's more towards end of life or very chronically ill patients. To clarify that too. So.
I'm not sure who the audience is, but I think it's important to clarify that in regards to the DNR, if you enact that, it's because the heart has stopped. A lot of people think they don't want to be a DNR because what if I'm choking? You won't help me. And that's not true. Of course, choking is a trauma. We're going to perform, the Heimlich maneuver. We're going to try to help you. The DNR really means do not resuscitate, meaning your heart has already stopped. I like to tell patients it's more of an allow natural death. If your heart has stopped and you don't want us to try and restart it, then you want to be a DNR.
And this doesn't mean do not treat.
Right.
So let's say if you're in a situation and you do need antibiotics or you need dialysis or you need these advanced treatments, this only refers to that situation only. So they will try everything up until that point to prevent it. But in that moment, then that's where they will just let you pass naturally and peacefully. But yes, like Nicole said, if something happens, let's say if you verbally tell someone that, I don't want these things, then yes, they can go against that. So it's best to have things documented with your signature. We always just say, sometimes even with me and Nicole, it's like, even if you just have the conversation, we're great with that, but it's best to have it documented that way. It does make everyone in this situation a little bit more clear because we see so much anguish and anxiety from having decisions made, especially in our case in the hospital. Likely it's in an emergent situation and no one makes great decisions in emergencies. And so we want to prevent that anxiety and that anguish and regret that families may feel when they're having to make decisions for their loved ones, because yes, they will say, I don't know if this is right. I don't know what they would do, because we've never discussed it. And so we definitely encourage each and every one of you to document that. Get copies, even your healthcare providers will make copies for you so you can give it to the person if you elect an advanced surrogate decision maker. You can have copies to them. We encourage that as well. Keep them in a safe place. Another thing I don't think people realize is if you say you do not want to be resuscitated and you don't have a form and you're in an ambulance, let's say, going to rehab after a hospitalization, and something happens to you and your heart stops while you're in that ambulance, if they don't have this form, they have to do everything. So that's where having these forms in place is really crucial, because really it benefits you. It not only benefits your family, but number one, it benefits you because you're the one that's going to have to go through all this, not them. They have all these other, psychological thoughts and experiences to go along with it, but you're physically the one that has to endure all this. So it's up to you on what you want to do.
I just want you to consider what people have said here. I think COVID had us think about this again and how dreadful that was in those sorts of situations when nobody had a clue. We still have COVID. So I'm going to stop there because I think they all did an absolutely fabulous job. Could we just give them a hand and then do something? What questions do you have for them?
Okay, my husband and I will be driving a long distance to attend 2 college graduations up in the Northeast in 2 successive days. Obviously, a dangerous thing for old people to do, but he does not want to fly. So, am I supposed to carry this DNR and this POLSD with me in the car in case we're in a wreck and injured?
Yes.
If you
Yes.
have them,
Yes.
This is
Yes.
the first I've heard of this.
Yes.
Okay.
Yeah.
Particularly the DD.
Yeah, if you know,
If you have that.
you can put the advance directive in your purse, but hopefully your family would have a copy, like your son or who you're visiting.
Yeah.
But if you are a DNR, DDNR, post, medical order, yes, make sure that's with you. Bye. And make sure you have it. They do have bracelets, things that you can get from like CVS, pharmacy to also, but you need to have the form, but that would at least alert them.
and also have your healthcare provider, especially a lot of hospital systems. We have electronic records, so a lot of healthcare systems share those documents. And so we will have them even from your doctor's office. They can send them to medical records, they can upload them in the system to where even another doctor that you might find in the system or even connected to their medical record can even search for those documents as well.
Thank you.
I just appreciate her clarification, because we have been in a situation where we were told that with my parents, if they signed the DNR, that even if one of them was choking,
Oh,
they would not count them.
That's the most common question that I get, yeah.
Um,
What if I'm choking? No one will help me,
Why would you
right?
say?
Right, right. Why would we stand idly by and let you do that? No.
Right. Yeah.
What do you do when the information on two different types of forms contradicts each other? Because someone forgot the earlier form, said this. You run into that?
Yeah, the most recent. And I should also add, the post form, if you have a post, that can also serve as a DDNR. So you don't have to per se have both forms. If you have a post and you want to be a DNR, it will serve as a DNR. So you don't have to have
Could you
the two
remind
forms.
us what POL stands for?
Physician orders for life-sustaining treatment.
P?
Physician orders for
Physician.
life-sustaining treatment. Because it's on the strength of a physician order or a nurse's order or whatever the state's orders from a healthcare professional will have.
My husband and I filled out power of attorney medical directives 25 years ago. And a good friend said, oh, be sure to say, if in the opinion of 2 physicians from 2 different institutions, you're not going to have quality of life again, then let this person go. Should I change that?
I think that's a preference. I think a lot of attorney offices, that's the wordage that they use, but in the Virginia Advanced Directive, it doesn't state that. It just says physician, doesn't say 2.
So what do you prefer?
I'd be fine with one opinion, but I'm not one to make. I think it's a personal kind of decision. If that's I mean, I think it'd be easy to have 2 physicians, you know, in the hospital, but I mean, it makes it a little bit.
And normally, we don't see really, we have several physicians involved, but they normally leave it to the head physician to say, here's what's going on.
Yeah.
So we don't necessarily require 2 physicians, even in the hospital, to sort of, you know, to have these discussions
Well,
that
and-
end of life is near.
The wording on mine is from 2 different hospitals. That's a big bother, you know, we're a small.
That's extreme, yeah,
I
that's
would,
extreme.
I would take the Virginia Advanced Directive in the back and just go ahead and update that.
And you know
Yeah.
what, honestly, like that's another piece of what your decision maker could do. I mean, if you feel really strongly, like, nope, you better be sure on what you ask 2 doctors. You better tell your decision maker. And that's something that they can then say, you know what, she really was adamant, this was part of what she wanted, so they can advocate on your behalf. But you know, from our standpoint and being in the hospital, that's not, you know, standard procedure. But again, you know, that's where you get to make this what you want it to be.
Yeah.
And I mean, I've seen advanced directives, and quite honestly, like I did my own when I was in school working on my master's degree. It was part of assignment. So I was 48 and I did my advanced directive. It is so specific, you guys. Like I have exactly who I want to be there. I want the kind of music. Like I've got it. I got it really laid out for them. They don't have to wonder. But it doesn't have to be that intense either. It can also just be as simple as, you know what, I'm gonna let you make my decisions and I trust you to follow my wishes. And that's okay too. It's just, it's really all about your wishes, and this is your opportunity right now while you're able to say, these are the things that are important to me. So that if and when there ever comes a time that you're not able to make decisions, you know you can have peace that you've made your wishes known. So.
And I think an important point to be made when I talked about barriers, a lot of times when I get into these conversations with patients and their family, the patient is not wanting to complete the form because they think that will give their son or daughter like complete control over their medical, you know, just decisions. So it's very important to know that this is only in the instance that you are unable to make decisions for yourself. And then as soon as you are able to, again, you will be the one making your own decisions. So you're always the one that's going to be doing that. This is in case of some type of event where that's not possible.
You know, I think many times when we talk about this, we have a sense of too muchness, you know, why are we getting obsessed with this? But I always think down the pike, do you want to be dealing with too muchness or not enoughness?
Yep.
And I know I work in this field too, so I've had this question come up a lot. People don't always think to ask it. Who would be making that decision if someone doesn't have the capability to make the medical decision anymore? Who would be responsible for making the decision?
For making the decision that the person can't make decisions?
Yeah, sorry.
Yeah, okay. So like determining capacity is what you're referring to. So in medical terminology, that's what we call it when a physician does an assessment that says yes or no, this person can make decisions on their own. Sometimes when people come to the hospital, they just have an acute something that's going on. Maybe it's a bad infection and they're just a little wonky. You know, they just can't think straight. In those situations, a physician would say they're going to do an assessment and determine whether or not they have the ability to make decisions for themselves. If that physician says no, you know, they're not oriented, they're not able to make this decision based on their, you know, professional assessment, then that's when that it would kick over to your medical power of attorney, your decision maker, to have that decision-making ability. And then as we've already said, in that particular situation, the infection gets better, the person perks up, and now they're back in their right mind. Guess what? Now it's their job again to make their own decisions. You're off the hook, decision maker, you know? So Does that answer what you were asking?
I just know how that comes a lot with other.
Yeah. Yes, sir.
Sorry, I'm not 100% clear on the answer from before for the question that I asked. So when you've written down exactly what you want to happen, and you also appoint an agent, who trumps who there? Like, does the agent get to say, even though whatever it says in here, I'm still gonna make this decision, or is it more, it's already been written down, you don't get to make that
If
decision?
it's a Virginia Advanced Directive, the healthcare agent can change the wishes of the person. If it's in a POLST form, a medical order, they cannot change that. So that's why we really focused a lot heavily on, it's so important to choose your healthcare decision maker wisely, somebody who is going to respect your wishes, because they can easily say, oh, I know mom said that she doesn't want treatment at end of life, but keep her alive as long as you can. So that's why that conversation piece and making sure you choose a person who is going to respect those wishes is so important.
And so if you had both a POLST form and an advance directive, the POLST would trump the
That's right.
advance directive?
Yes, ma'am.
Okay.
And they're really meant to be kind of like paired. They don't like, it does trump in the sense of when you get into like CPR or no CPR, but really the advance directive is still really important because that is the form that's saying who's going to be your decision maker. So they kind of couple each other. But when you get into actual medical treatment and the physician's order, you're looking at the POLST, yeah.
I wonder, I was gonna ask, when does a person, but about the POLST, I think probably need to tell them when people usually execute a POLST, because it's not usually done
Right.
Right, so that's, I was actually going to elaborate on that, in the fact that, so when someone chooses a POLST form, an advance directive can be just in general, I don't want these things. This gets more specific to, okay, these things are happening in my life or could happen very soon in my life. I'm at an end-stage disease process, I'm very ill. This could be very specific. You can be very specific in the advance directive, but this really narrows it down once it becomes an order that is solid. Same thing with the do not resuscitate. If you sign this form, no one can change that because that's an order. And so I would recommend that if you wanted to do a general advance directive, that's in your current state of health, you're really not in the hospital very often, you just want your wishes to be known that if something did happen, this is it. But if you become seriously ill and you find yourself, especially repeated hospitalizations, you find yourself just not getting better, just getting worse over time, this is where this becomes very informative because you have a serious discussion with your doctor about, okay, here's where I'm at now, we see this going in this direction, that's not good, and all these things can be done to me, but I don't want them, and that's where you can be very specific on this form.
Where did the medical power of attorney come in this, that they would be able to trump any of it, or?
So, again, like if we're just talking about an advance directive, and just remember, I think we're probably confusing with all the different forms. So I'm gonna talk just again about the advance directive. So on this, remember it's two basic sections. Number one, I'm determining who will be there's a lot of terms for it, medical power of attorney. What did you call it?
I call it
Medical
SDM.
Surrogate decision maker.
Agent is.
Agent, there's a lot of names for it, but basically the message is, this is the person that's gonna be making decisions for you. So that's the first part of this advance directive, is you're determining that person. Now, I think it has been mentioned, but there's a section for, this is my first choice, and oh, by the way, if that person can't do it, won't do it, whatever, I'm also gonna give you a second choice, just in case, and that's a wise thing to do. The first choice is still gonna be, that's gonna be your primary person, okay? The second part is the advance directive, and that's exactly what it is, a directive. This is just me taking the time to state my wishes, that if I'm in a situation, and the really simple form just has basically two options. If I'm in a situation where my doctor says that I have a terminal condition and I will not recover. And you got 3 little boxes to check. Number 1, and I'm just gonna give you this example so you guys can kind of picture it. Number 1 is do everything no matter what. I don't care if it's terminal, do it all. Number 2, I don't want anything. Please make me comfortable. Or number 3, fill in the blank. You write out exactly what you do want. Maybe there's some mixture of that, and that's an opportunity for you to state exactly what you want. So that's scenario number 1. I have a terminal illness, okay? Scenario number 2 is if I am in a vegetative state, meaning I am not aware of my surroundings. I may still be breathing on my own, my heart's beating, but I have no awareness. I'm in a persistent vegetative state. And it's the same choices there. Do I want to, keep doing it all, everything, give me tube feeding, dialysis, put me on a ventilator, do it all, no matter what. Or second choice, please don't do any of that, make me comfortable. That's not quality of life to me. Or the third option, again, you have a fill in the blank. I'm gonna write out exactly what I do and don't want, and maybe it's some mixture of that. So that's kind of just in a nutshell what it is. And so what we're saying is that section, those sections that I'm just now talking about, those scenarios, that's the directive piece. That says, these are my wishes if I ever get in that situation. But this is the person that's gonna make the decisions. So what we're saying is that person, even though, let's say my mom has chosen me to be her medical power of attorney, and I'm in a situation now where I have to make decisions for my mom, and I have her wishes right here in my hand. I know what she wants. We've talked about it, it's right here. Ultimately, even despite what she said, ultimately that decision making rests with me. I'm gonna be the one that says to the doctor, yes, go ahead and put her on dialysis, or go ahead and put her on a breathing machine, whatever. Even if her wishes said no, because now I'm the decision maker, that decision rests with me, no matter what she said. But that, again, is why it's so important to choose someone who's gonna follow your wishes, and why it's so important to talk to them about what your wishes are. But at the end of the day, they're the ones that make that call with physician guidance. Let me put that out there. They're not going in and just telling everybody what to do. Does that kind of clear it up, make it a little more sense?
Just to clarify as well, for the Virginia Advanced Directive, it's to your signature, but witnessed by 2 people. Okay, just so you know, so it's not just your signature, 2 people need to witness that.
And I will say that we've come up with this at the hospital, that someone was here from another state and they didn't have two witnesses, and they do not honor that in Virginia.
Yeah.
So no matter what, I'd say, I counsel everyone, no matter what, even from another state,
Yes.
you might as well just get 2 people to witness it, because it may not be honored somewhere else if you have if you have an advanced directive.
Yeah.
I have a couple of questions. One, back to that question, can you specify in the advanced care directive and say what I've written here holds that the agent does not have? They can't contradict what I've already said here. Because there's options here to say, because I've read it, and it says I don't give my agent these powers. And could they not say, I don't give my agent power to contradict me, as I've already written here? That's one. And then the other question was, especially when it comes to the post form, there's lots of procedures that they do, and we don't really know what those procedures are, what kind of cost benefit analysis there is, how much suffering there is versus how much benefit there is, and all of that. So where can you make, how can you understand that to fill out that form? How do you know what to pick?
So on the POLST form, that's the one that you're gonna sit down with your physician, and they're the ones that are gonna go through and have those exact conversations with you as you're making those decisions. So that's where that teaching piece would happen. That's a one-on-one with your physician or your provider, and they're explaining exactly those things you just asked.
There's also facilitators, certified facilitators in the state. So you'll see a lot of social workers like myself in the hospital, home health, hospice. So they can also do the pulse and start that conversation and walk you through it. But it's still a medical order, so then the physician would pick up and finish that conversation. But yeah, so you wouldn't be doing that one on your own. Yeah.
But could you put in the, I mean, her other question though was, can you put in the DPOA document, I direct my SDM not to, or sue them? I mean, you could put it.
Right, because one thing we get into is why do the documents if someone's gonna override my decision?
Right.
So if somebody comes to me and they have that document and what's on it, then we're gonna go by it. And especially if it has statements like that or they're very clear that I do, despite me electing this person to make decisions for me, I don't want this overturned. Then yes, I'm gonna honor that. I know every doctor that I work with, they're gonna honor that.
Yeah, and I think, obviously when you get to a situation like that in a hospital, there's a lot of ethic, like groups that come in and kind of go over that if there is an issue. So if there's specific wishes, write it in.
Yes.
Could you say 100%? I don't feel like I could say 100% that would be honored, but I would hope it would be, from the clear instructions, the physician going over that, and then also bringing in any type of ethics, advisor on that situation.
You're gonna make a comment.
I just had a quick question to clarify. On the advance directive with the witness signatures, should that be notarized, or does some kind of signature hold more weight than another?
This form does not need to be notarized, just witnessed by 2 people. I do recommend it not be the agent that you pick. Virginia law, though, does allow that, but if you can have 2 other people, I would definitely do that.
Should it be family members, or should it be people that live in different households?
It can be whoever. Just 2 people. It's a good question. And they have to be 18 though.
Other questions?
What if you don't want any organs donated? How do you arrange for that?
That you do not want to be an organ
You don't
donor.
want any, and
So on the
your
advance,
children,
yeah.
even if you tell them, but if you're very much against that, what do you do then?
There's actual spot section on the advance directive that asks about organ donation. Just cross that out. Yeah, cross it out, and that will be honored. Yeah.
Thank you.
Of course.
And that's a good point, is on this form, any part that you don't want to fill out, just
Cross
mark
it
it
out.
out.
That way no one can go back and fill in anything. So if you skip a part and you don't want to do that, cross it out. Yeah.
I do want to get the word out, just contact the Veterans Administration.
Mm-hmm.
They are incredibly helpful. Sometimes it takes a long time to get an answer. But not all the funeral directors know that these things are available. I know that McCoy has done so many funerals for my family over the last 50 or 60 years, but they even had some material out in the lobby about veterans and what they needed to do to apply for maybe even benefits for the spouse and things like that. But they weren't pushing it because they didn't realize that the previous director had the information put out there. So that's a resource for you. Can save a lot of money. But also, if the veteran is proud of having been a veteran, then sometimes it means a lot to them.
Great, thank you for sharing. I think it is 5:20, and I think probably that if you want to, maybe you'll all stay around if somebody wants to ask you.
Sure.
Well, why don't we draw this to a close, and thank you, gosh, so much for coming.
Thank you guys so much for being here and taking your time.
Good job.
Yeah.